So for my fellowship visit, I travelled to Cancer Care Ontario in Toronto to observe their knowledge transfer and exchange activities. And the first thing I suppose to say about this area is that there's a lot of vocabulary associated with it, and all these terms do mean something a little bit different, but trying to wade through it, that's exactly how I felt. I suppose what draws them all together is that they all have something to do with closing the know-do gap, what we know and what we actually put into practice. For any purists, I did find this reference, which actually sort of teases out all the differences in all those different terms. The World Health Organization defines knowledge translation as the synthesis, exchange and application of knowledge by relevant stakeholders to accelerate the benefits of global and local innovation in strengthening health systems and improving people's health. So it's a very broad definition, and it does incorporate a vast array of activities, including right from the generation of that evidence and through, for example, research activities, to synthesis of it, interpretation and dissemination through lots of different means. And it also includes lots of different types of evidence, so it's not just research evidence, it's other types of knowledge, it's practices and policies and organisational structures and so on. It is important because the US and researchers from the Netherlands have done some reviews on this type, and they've estimated that between 30 and 45% of patients are not receiving care according to scientific evidence, and 20 to 25% of care is provided is unnecessary or potentially harmful, and also that it's estimated that cancer outcomes could be improved by 30% by application of what is currently known. So by actually putting into practice the things that we already know, we can achieve real differences rather than further investment in more research is obviously also important. But the problem is that the papers are in the filing cabinets, they're online, they're on people's desks, the best practice guidance and so on and so forth, and it doesn't, it's not self-executing. It actually takes a lot of effort to get from that stage into practice. So there is now a recognition of that, and there are now journals dedicated to implementation of evidence. There's funding schemes now to look at knowledge translation and putting research into practice, and sort of using that evidence as best we can to create real change in the health service. And it's partly because researchers and clinicians live in very different worlds, and it's not very often that they meet. So there is more of a now an impetus on the researcher to have impact. So the ref in the university system now includes an assessment of how you actually impact on the community, on practice and so on and so forth. So we are starting to move towards a better system for that. It's also important if it goes wrong. Basically, I mean, these two are examples that are often quoted of where knowledge translation has gone wrong. The Challenger disaster, apparently the scientists knew about these problems, but it just wasn't really translated or transferred to the decision makers. And we often hear people talking about the war in Iraq as well as the evidence or lack of evidence was there, but the system, the process, the transfer didn't work correctly. So I was interested in this gap between what is known and what is implemented, and particularly in palliative care. In Curie, both nationally and locally, we're interested in knowledge transfer, putting research into practice and so on. But we also recognise that it is actually a really complex endeavour, and there are a lot of factors, individual and organisational level factors, which impact on successful knowledge transfer. So Cancer Care Ontario are a big organisation which have a lot of resources put in around knowledge translation. So I travelled there for just over a week, spent about a week, a very busy week of meetings with different people to learn about their processes and procedures around knowledge transfer. So just to say a little bit about Cancer Care Ontario, they oversee the cancer care services in Ontario, directing more than $800 million to hospitals and cancer care providers over a massive area. They're responsible for the development and monitoring, reporting of progress on their Ontario Cancer Plan, and they ensure that the 14 regions within Ontario put provincial cancer standards into practice at the point of care. So it is a very top-down structure, but they are responsible for making sure that those policies and procedures and things which are developed are disseminated widely. They have various clinical programs and responsible for the transfer of best practice in a specific clinical area to the regional point of care. So I just want to summarise what I learned from the visit. So these are only my observations. This isn't a comprehensive synthesis of what they do, and it's not necessarily a model for other organisations like ourselves. It really is just what they do, and not all of it worked as effectively as I'm sure they would have liked. But I think there are some examples that we can learn from. And I'm going to use one of their clinical programs was this interactive symptom assessment and collection program. So I'm going to use this program as an example. So this was a program that was developed and then was sort of disseminated throughout Ontario, and it was a major task to do this. So I'm going to use this example as I go through looking at the processes that they used. And the initial motivation for this program was in palliative care. So in Canada and in Ontario, there was a recognition that at once palliative care 10-15 years ago was a bit of a mess. There was a lot of uncontrolled symptoms, a really high rate of admission to emergency room, and a lot of variation in the quality of palliative care across Ontario. And so they identified a need for attention to symptom screening and assessment and management. And one of the best ways they thought of doing this was, first of all, to record symptoms and to actually assess people's symptoms. So they aim to improve palliative care by implementation of a common, valid and reliable tool for screening. And they eventually, the aim was to have this common tool delivered by electronic means. So in most cancer centres now in Ontario, when someone goes in for a visit, they go to a kiosk like this, or a little touchscreen computer or some sort of electronic portal, and they get some symptom screening. So they use the Edmonton Symptom Assessment Scale. Some centres use additional questions depending on the disease site and so on. But everyone, as part of their minimal data set, everyone completes on every visit the ESAS, the Edmonton Symptom Assessment Scale, and records their symptom profile on the shortness of breath, and depression, anxiety, and general well-being, and so on. So that's the example. How did they roll that out? Because you can imagine that is a massive task, and it requires a lot of people to be engaged throughout those regions in a really large area. A lot of it's quite remote. So I suppose the first thing that I noticed was that they used quality improvement and change management approaches. So they were quite theory and model driven in their approach to implementation of this. So they gathered a lot of evidence to suggest that, research evidence to suggest that routine symptom assessment were more likely to pick symptoms up than if just general questioning of the patient. There were some symptoms that people were less likely to divulge unless there was sort of standardised or systematic questioning, and that having this system in place helped to reduce ER admissions and improve symptom management. So, but it was a matter of getting that information out to everyone and encouraging them in various different ways to actually take on this initiative. So they were guided by, and there's lots of different change management models out there. The best known ones, I'm sure you've heard of, Cotter's change management theory, there's Rogers diffusion theory, and then there's a set of sort of change management approaches which have been developed by the Institute of Healthcare Improvement in the States, and that's the approach that Cancer Care Ontario took. So so they're actually using these IHI approaches to accelerate change. So I know it's very busy looking, but the Breakthrough Collaborative is basically just a generic quality improvement model for producing small but rapid change through local multidisciplinary teamwork. So it basically starts off with, and this is why it's still kind of a top-down structure, and that it starts off with a vision, so a group of experts at the top who decide generally what they want to do. There's some initial development of ideas and planning, and then they engage in some pre-work. So pre-work and engagement of more local teams. So there's a stage where they actually engage with clinicians and staff regionally to find out, to assess their readiness. This is a symptom assessment program. Teams may already, may already be using a different system, a different tool. They may not see the necessity for a tool. There are lots of things to assess in terms of, are people actually ready to take on board this new initiative. They assess training needs. Do people need training in terms of administering sort of these patient-reported outcome assessment tools and scoring them and interpreting the data and things like that? And to assess even their system readiness. So some of the regions they found did sort of use iPads as part of their routine work, so that was straightforward. Others didn't really have the resources set up for this sort of patient reporting portal, so we needed a bit of investment there. But also just to learn, as I said, what people are doing, because the change has to be perceived as better than the current practice, or there will just be resistance, and for good reason. So that stage is all about assessing sort of the local priorities and the local readiness and the local perspectives. And the Breakthrough Collaborative provides a structure for doing that, basically. So then you go into these cycles of what's called Plan, Do, Study, Act, and you alternate sort of learning sessions with these action sessions. So learning sessions, the initial learning session is where the team of experts along with local champions who they've already got on board will present the vision. Then the team is tasked with going away and taking that vision and seeing what can they do to implement it locally in a small way, a small step towards that vision. But they're given the autonomy to make some changes. So, for example, they could choose to do a pencil and paper test, not necessarily electronic. They can choose where to have their electronic portal, how to implement it, at what point in the visit do they ask people to do it, who asks people to do it. Some have had like a team of volunteers who man these stations. So there's a lot of local contextual things that the local team are given autonomy to change. They come back then basically and review that progress, review any problems they have, feed that back to the team. Further learning might be identified as a result of that. They might, teams needed some training on sort of the principles of patient-reported outcomes, that they should be patient-reported rather than clinician-reported and things like that, and that sort of assessment of minimally important, clinically important differences in these symptoms and so on. So they alternate these learning sessions with the action sessions, and this goes on, and it's meant to take between 6 months and about 15 months before you have a real change. And as part of this process, there's also a continual assessment of the impact of that change, and that's really important. You have to collect data through this process. The key to it is really collecting data on the change, so that people who are involved with this change can actually see the impact of their efforts. Otherwise, why bother? And the local teams were getting a lot of support from the provincial team in doing that, so maybe in terms of collecting data and summarising it and disseminating it in sort of user-friendly ways. Okay, so those alternating cycles, other types of support coaching and phone conferences and visits and so on, and then disseminating those findings and trying to hold those gains, so trying to incorporate them into the clinical process, so we actually keep them as a central part. So, I'm not going to spend long on this, but so this Plan, Do, Study, Act, I'm sure a lot of you are familiar with it, but it's based on these 3 questions, actually tying down what are we trying to accomplish? How will we know that a change is an improvement? And what change can we make that will result in improvement? And a lot of clinical teams wouldn't have been familiar with this process, or even this type of structured process to making a clinical change. So they were given training on the Bantu Study Act cycle, and the idea was to generate numeric information to assess these things, and then, as I say, run with that and measure the impact if there is one. So the model isn't really meant to change existing change management programs, it's just meant to accelerate it a little bit. And so as part of this cycle, basically there's three things that I observed that they seem to do a lot of, was educate, evidence and electronics. These things were central to their education about symptom assessment, the importance of symptom assessment, that they educated relevant staff about the high prevalence of symptoms, which you're obviously aware of, but also that there is evidence there to say that symptoms are underreported sometimes in the patient-clinician consultation. So there's the problem. They've identified a problem. Do clinical teams see that problem? Can they relate to it? And then a solution. So the change that they were trying to promote in terms of routine assessment of symptoms, and particularly electronic assessment of symptoms, there's evidence to suggest that more symptoms are reported when you use a standardised instrument. There's a reduction in emergency room admissions, and there's reduced symptom burden and patient distress as a result of those. So, I mean, the key thing for me there was there's lots of evidence around symptom assessment and so on, but they really just honed in on a couple of key factors that were clinically relevant and clinically important, and focused very much on those, and reducing emergency room admissions at the time was one of those. So they also very much listened to the teams, and they obviously had challenges, so they were worried about things like, will using this electronic symptom assessment impact on the consultation time? So then the provincial team would have gone away and gathered some evidence, or tried to generate that evidence themselves about the impact of using this assessment tool on consultation time, and came back with that evidence and presented to so for example, they found that there was a negligible increase in consultation time, but what it actually helped to do was focus the consultation more. They also, for example, listened to staff concerns about the Edmonton instrument. So people were using other types of instruments. People had their preferred instruments, and for measuring symptoms, and that'll always be the case. So they tried to listen to those, and then for example, let teams add other questions if they felt that the Edmonton didn't cover all the important symptoms or characteristics. So these are sort of overlapping constructs, but in terms of evidence, again, so they used research and evaluation evidence to address key clinical outcomes that were of interest to clinical staff, and had to go and ask the staff what they are before they actually address those. In contrast to sort of the perspective of a researcher, we would like to see if there's international evidence for something, but they very much used local evidence that was much more meaningful to clinical staff if there was a local impact on patient symptoms or hospital room admissions, because then that's their population profile and characteristics, and that effect has been demonstrated in the most relevant environment to them. Any evidence that they did gather was disseminated with local clinical staff and service users. So evidence was presented to clinicians by clinicians, and they also have some evidence review services, so some resources that they can draw upon to gather evidence and to summarise it in reader-friendly formats and so on. So, and the other domain that they used was electronics. So they did try to capitalise on electronic solutions where possible to try to reduce the burden on the clinical processes. So if there was, so the idea was that the electronic symptom assessment would reduce burden. It would stop staff having to score a questionnaire, interpret the scores and feedback and so on. Can staff do that in real time? The electronic system could. So patients recorded their responses, and then a summary of those responses were generated automatically for the patient and for the staff member. So this helped to produce and promote sustainability in practice change. It becomes part of the automatic process. It also reduces risk of errors in scoring and administration, that's obvious, and they were also able to build in some smart programming. So there's a potential advantages here when using an electronic system like this to say, well, for example, if someone scores an 8 or some sort of cutoff on anxiety, then automatically it will generate an email to alert someone or whatever is relevant to the clinical team to kind of remove some sort of burden on, or middleman that can be removed. And there's lots of different types of smart programming you can use. Other centres in America who use this type of programming actually use it to identify staff in research trials. So, patients in research trials. So a patient might come in to do their routine symptom assessment, but the computer says, "Well, you're in this research and it's time. Time to. You need to fill out this questionnaire. You need to do that or that, or get this blood test." So, and they automate the processes there as well. So it can be used for lots of things. It also used to aggregate and pool data, so you've got all this information and you can evaluate outcomes, so you don't then have to think about the certain audits or service evaluation. If symptom assessment or management or whatever are the outcomes, then you've got this information sitting there and it's being collected all the time. So it does provide a lot of opportunities for assessing the evaluation of different programs that are implemented and so on. It can identify patient needs, so you can incorporate, so you can look at your patient profile and say, well, everyone, our patients seem to be having bother with anxiety. Maybe we need to look at our social services or whatever, and you can identify that need over time and how it changes after you put that new service in and so on. Feedback of that obviously to the clinical teams and any relevant institutional committees, and talk about that afterwards, and also help it. By using these databases and pulling the data together, you can anchor the practice and performance metrics. So that may or may not be attractive, but that's what CCO use it for. So they then have a big database. Every region has information, has data collected, what percentage of patients are screened, what's the profile of those patients, and so on and so forth. And you can see that at a provincial level, regional level, right down to the individual clinician level. This is, it's not very good quality, but so for the patient, after they fill this in, this is the type of output that might be generated. So this isn't a real patient, but so they use it, the patient gets in and they can see their symptoms and how they've changed over time. So there is some discussion around it, whether this is a good thing or not in palliative care, because patients may be seeing a deterioration, but that's what they use for. There's different formats it can be generated in and so on. So they also make very effective use of this data and really as a powerful motivator for knowledge transfer and practice change. So those things I've already mentioned, to demonstrate changes in clinically important outcomes as a result of any practice change that people make. Data can be computed and reported provincial level right down to the individual clinic level, and to overcome scepticism among staff. When you're trying to present a change to people and you're presenting the evidence is never that clear cut. There are always nuances in research that someone can say, but their profile of patients is different from ours, and so on. If you have the data from your own team, it's much more convincing in that way. So they can also use it to make regional and international comparisons and against provincial or national quality standards. And that's what they do. So Cancer Care Ontario are also governed by a body called Cancer Quality Council of Ontario. And Karen, if you would just click on the link. So they actually collect all this information and assimilate it and then produce, they have a website, publicly available website, where you can go in and you can look at all the different regions, and coming eventually, and you can see sort of symptom profiles and different practices. So this is the website, but we'll just skip that. See if you just click on figure 1, for example. So that's the percentage of cancer patients who are screened at least once a month by regional cancer centre. There's all the regional cancer centres across the bottom. You just go to the arrows and skip on with it. There's so much information available there, and it's all publicly available. But people, obviously, the centres are also held to account. So it's a different system than here. Cancer Care Ontario control the purse strings, and the ultimate motivator will be, don't get your funding if you don't reach 70% of patients screened or whatever. So, but that's not, that's the bottom line, but it's not really used like that. And the feedback to me was that people find this as a real motivator. They can see in their clinic that their performance is going up, and if they try to make a quality improvement change, they can see the effect of that and so on. So yeah, if we just go back to the presentation. So the last key characteristic that I observed was engagement of clinical staff. So all these change management models, including the IHI models, stress the importance of engaging and enabling and preparing people, identifying and anticipating barriers and trying to create solutions along with those people who are going to be using the solutions. Some changes like this one, where they're implementing this assessment system, are really significant, and if they're not wanted by the staff, they will not be successful, and there's just going to be resistance encountered. So they have tried to involve staff who are at the front line in the process from the beginning, or almost the beginning, and just to show them how this change will actually support their work, and to build it into something that will support their work. So they have this structure of provincial and regional clinical programme leads who lead and direct the knowledge transfer activities, and they are people who are still working in the region, so they're a credible source. They're not kind of an academic or someone who doesn't understand their priorities. They're the link between Cancer Care Ontario and the local staff. They try to identify people with a real profile in the area, so someone who's very well respected, a thought leader in the area to do this. They also provide funding to help teams do this, called the Improvement Initiative, so buy-out time for staff and so on, and they provide a lot of administrative support and sort of data analysis and IT support as well. The clinical leads continue to practice in their area, in their geographic and specialist area, and they also provide IHI Open School membership for key staff. So key staff who are leading change get training in change management through the Institute of Healthcare Improvement. And I suppose something that we all try to do as well is that any results generated from these QI initiatives are co-authored by clinicians and in mainstream journals, again, just to demonstrate the credibility of their results and the publications. So, in summary, in Cancer Care Ontario, as I observed it, their knowledge transfer and exchange approaches are theory and evidence and model driven. Data is central in demonstrating clinical need and demonstrating improvement in motivating change and sustaining that change. The structure that they have is largely top-down, but they do try to incorporate all this clinical buy-in. And before I finish, I'd just like to say a big thank you to Karen and Michael, who really helped we set up the visit, and I also did have a lot of help from people in Cancer Care Ontario and other sites that I visited. I can't put them all up there, but they were the key folk that that we worked with. And there are some resources, so if you're interested in knowledge transfer, well, first of all, the full report is on the website, but the IHI do have improvement resources which are free to all, and this KTE toolkit is from a Canadian organisation, and they have a wealth of information about change management and KTE, anything you could really want, and that's just the website, the Cancer Equality Council of Ontario. You might be interested in that. So, that's it.